Hello everyone. Today we'll discuss about multiple pregnancy. So first we'll start with their classification. So classification according to the zygosity, it is classified as monozygotic and dizygotic. In monozygotic, they originate and develop from a single fertilized egg. So they originate and develop from single fertilized egg. Okay. They have same sex and they are identical twins. They account for 20%. Okay. Next we'll see for dizygotic. So they develop from two separately fertilized zygote. So these develop from two separately fertilized zygote. They are of different sex and these are non-identical and they account for about 80%. This is about their classification according to their zygosity. Next we will see their according to the day of their division how they being classified. If suppose the division takes place within 72 hours, so this is division time. If the division happens within 72 hours after the fertilization, they are called as dichorionic and diamniotic. So if the division happens within 72 hours after the fertilization, they will be having two separate, this picture in the A picture. So that is they will have two separate placentas, two separate amnion and two separate chorion. Okay. So this is called dichorionic and diamniotic. If the division happens within 4th day to 8th day, they will be having monochorionic and diamniotic. So that is in the picture C. They will be having one chorion and two amnion. These are amnion. So these are monochorionic and diamniotic. Supposing if the division happens after the 8th day, they will form monoamniotic and monochorionic. They will be monochorionic and monoamniotic. This picture D. This is they have only single chorion and single amnion. So in picture A, we have dichorionic and diamniotic twins with two separate placenta. While in picture B, it is dichorionic, diamniotic with fused placenta. In picture C, we have monochorionic and diamniotic. In the picture D, it is monochorionic and monoamniotic. Supposing if the division happens after 2 weeks, it is very rare. If it happens after 2 weeks, you will be getting a conjoined twin. Okay, so this is the classification according to their division time. Next we will see the causative factor for this multiple pregnancy. So causative factors, so there are two main causative factors. It is because of, first one is increased use of fertility enhancing therapies. It is increased use of fertility enhancing therapies nowadays, such as artificial reproductive therapy, in vivo fertilization IVF, or it can be non-ART, that is by using the ovulation inducing drugs, or by artificial insemination. Second, it can occur due to older maternal age group. Older maternal age group, here the age group they have specified as, it can occur when the woman is between 35 to 39 years. Why? The reason here is there will be an increased level of FSH in mother have been associated with this zygotic twinning. In older maternal age group, they can have a increased level of FSH in this maternal age group. So these are associated with dizygotic twinning. Okay, these are the two main causative factors. Next, we'll see how they're going to diagnose this. This can be diagnosed by the USG as early as 5 weeks. So diagnosis, this can be done by USG as early as 5 weeks of gestation. So dichorionic can be at weeks of 10 week to 14 week. We can differentiate or distinguish dichorionic and monochorionic twins. In this is dichorionic. In dichorionic twins, they will be having a 2 achorion and 2 amnion will be present, so that this layer will be thicker. This one will be thicker in dichorionic pregnancies. So the thicker base, the base of the membrane will have a triangular projection, which is called as twin peak sign or a lambda sign. So since they have 2 chorion and 2 amnion, base of the membrane will form a triangular projection. This one, this triangular projection, this is called as twin peak sign or lambda sign. Why this thicker projection occurs in dichorionic is because of it is extension of the placental villi into the potential space that is formed from the reflection of this opposed amnion and chorionic layers from each fetus. So this occurs due to the filling up of that space by the placental villi. So extension of placental villi into the space, potential space that is formed between the opposed amniotic and chorionic layers from the each fetus. Okay, this is about the dichorionic twins. In monochorionic twins, we will be having this T sign. Okay, it is because they have only 2 layers of amnion. It is because of a thin layer of amnion from each of this fetus. So they don't have this filling up space because it is not thicker. So it is called as T sign. It is an internal dividing membrane. It is because of lack of chorion. This is, I'll write it here. In monochorionic, it is T sign. Okay. Due to lack of chorion. So this is how you diagnose the differentiate this monochorionic and the dichorionic twins. Other biochemical tests are which are non-significant. Here we have maternal serum chorionic gonadotrophin, maternal serum chorionic gonadotrophin, alpha fetoprotein, and unconjugated estriol. These everything will be doubled than those of the singleton pregnancy. This will be doubled in multiple pregnancies. Okay. This is the biochemical test, but this is not very significant, only for multiple pregnancy. Next, we'll move on to the neonatal complications, fetal and neonatal complications. First, it can be prematurity and low birth weight. Second, IUGR. So the fetal growth is independent of the number of fetus till 30 weeks of gestation. So fetal growth is independent of number of fetus till 30 weeks of gestation. Okay. After that, the growth of the twins falls off gradually. So what are the mechanism involved in the decrease in the growth of the fetus? We'll see here. So after which growth of the fetus decreases gradually. It is due to the mechanism involved here. It can be due to uterine crowding. Second, because of limitation of placental perfusion. Third, it can be due to anomalous umbilical cord insertion. Fourth, it can be due to fetal anomalies. Or it can be due to maternal complication like pregnancy induced hypertension. Okay, these are the reasons for IUGR in a multiple pregnancy. Third complication can be fetal growth discordance. So what is fetal growth discordance? So it is difference in the birth weight of more than 20% of the larger twins weight. So it is difference in the birth weight of both the twins. The difference is of birth weight is more than 20% of the larger twins weight, or from the larger twins weight. So they have classified this fetal growth discordance into mild, moderate and severe. So when the difference is less than 15%, it is mild. Moderate is when it is between 15 to 30%. Severe is more than 30%. Okay. So the risk factors for this discordant growth include. So what is the why does this fetal growth discordance occur? What is the major risk factor for this? So risk factor for this is when they are a monochorionic placentation, not only with monochorionic placentation, when they have monochorionic placentation along with placental dysfunction, when the mother has a preeclampsia, when the fetus have an infection, that is fetal infection, or when they have a chromosomal abnormalities, or when it is associated with twin-to-twin transfusion syndrome. So these are the fetal growth discordance risk factors. Next complication is intrauterine fetal demise. So intrauterine fetal demise refers to a fetal demise after 20 weeks of gestation but before the delivery. So it refers to fetal demise that occurs after 20 weeks of gestation but before delivery. Which is confirmed by the USG evidence of absent fetal cardiac activity. Okay, this is called intrauterine fetal demise. So this risk of intrauterine fetal demise is more common in monozygotic twins. It is more common in monozygotic twins. So what are the risks can occur if there is a intrauterine fetal demise? So almost all the monozygotic twins have a placental vascular connections. They have a shared vascular connections. So mostly, so monozygotic twins, they'll be having a shared vascular connections. This can result in the risk of neurological injury. This neurological injury in the surviving twin. This can be due to, or this can be associated due to severe hypotension or thromboembolic events upon the death of the co-twin. So there can be a risk of neurological injury in the surviving twin due to associated thromboembolic events from the death of the co-twin. Okay, this is the fourth complication, that is intrauterine fetal demise. Fifth is vascular disruption syndromes. Vascular disruption syndrome is due to presence of large vascular anastomosis between two embryos early in the development. This can cause an unequal arterial perfusion. It is because of large vascular anastomosis between two embryos early in the development. This can lead to unequal arterial perfusion. This results in what is called as twin reversed arterial perfusion sequence. It is twin reversed arterial perfusion, that is TRAP. Sequence. Here this occurs only in the monochorionic twins. Okay, this occurs mainly only in the monochorionic twins. In here, one twin is a parabiotic twin which lacks the functioning of the cardiac system and receives blood from the normally developing twin. So they lack the normal functioning of cardiac system. So this receives blood from the normally developing twin. This normally developing twin is called as the pump twin because it is pumping the blood to this parabiotic twin. Since this has to pump, the one heart has to pump the blood for both the twins, this condition places an increased demand of the heart, on the heart of this pump twin, that is a normally developing twin. This leads to the risk of cardiac failure in the normally developing twin. So this is called a twin reversed arterial perfusion sequence. So why it is called as reversed arterial perfusion? So normally it is because in trap sequence blood enters the abnormal twin through the umbilical artery. So it is called as reversed arterial perfusion. Why it is called as reversed? So blood enters the abnormal twin through umbilical artery. But this umbilical artery normally carries the blood away from the fetus to the placenta. But in the abnormal twin, blood enters through the umbilical artery. Okay. The blood then exits through the umbilical vein. But normally this umbilical vein will carry the blood from the placenta to the fetus, but it is reversed in this abnormal twin, so it is called as reversed arterial perfusion. So this is called as vascular disruption syndrome. Next complication, it can lead to deformities. Deformities like club foot, dislocated hip, cranial stenostosis. Okay. The next most important complication which will be asked as a separate question is twin to twin transfusion syndrome. This one I will discuss it as a separate topic. Okay. So this is about the multiple pregnancy. Thank you. Please like, share and subscribe my YouTube channel. I'll post the PDF of these multiple pregnancy in our Telegram group and also in the Instagram page. This is my Instagram page and also in the Telegram group. That is PEATS University Exam Discussion Group. Thank you.